Dr. N. Raja, Senior Consultant Geriatric Physician from Madurai. I am practicing in Madurai for the past 20 years, and I am a Senior Consultant Geriatric Physician from Preeti Hospital, Madurai. Today, my topic will be centered around the latest update in hypertension. And needless to say, as per WHO, nearly 63% of total deaths in India are due to non-communicable diseases, of which 27% are attributed to cardiovascular disease, which in turn affects 45% of the people between the age group of 40 to 69. And the rise to blood pressure, that is the hypertension, is among the most important risk factors for cardiovascular disease, apart from other risk factors like diabetes mellitus and dyslipidemia. However, it remains poorly controlled, maybe due to the low awareness among the public regarding hypertension and lack of appropriate care through primary care. And not only that, poor follow-up also is being involved as far as the management of hypertension is concerned. You would have heard of a proverb that rule of half in hypertension. That means roughly 50% of the patient are hypertensive, and of the 50%, only the 50% are being diagnosed. That is, only 25% are being diagnosed. The remaining 25%, they are not diagnosed. Of this 25%, only 50% they are on drugs. That means 12.5%. Only 12.5% they are on adequate drug therapy. And of this 12.5%, only another 50%, only this 50% are being taking the medicines regularly. That means it comes to around 6.25%. And of this 6.25%, only 50% are being adequately controlled with the proper drugs. That means only 3% of the population is being properly diagnosed and also properly treated. Not only that, they are being properly controlled with various drugs. So there's only 3% of people being adequately treated. The remaining 47% of the people, they are not on proper drugs, or they are not on proper follow-up, or they are not being adequately diagnosed, properly diagnosed. So in India, the prevalence has also gone up over 30 years to 38% in men and 32% in female population, which was from 29% and 28% respectively. So there is a staggering increase in the age group beyond 30 years also. And additionally, over 62% of the men and more than 53% of the women living with hypertension did not get treatment. So this was one I was just now I was telling. So the medication was used to control blood pressure in fewer than 1 in 5 men and 1 in 4 women with hypertension worldwide. This is according to the Lancet 2021. So how we are going to approach this hypertension? This International Society of Hypertension has released ISH 2020 Global Hypertension Practice Guidelines, in which they clearly mentioned about the inclusion of optimal and essential treatment paradigms attempts to address the issue that increases poor settings. What is meant by optimal care? That is, optimal care refers to evidence-based standard of care, whereas the essential standards refer to minimum standards of care to allow specification of essential standards of care for low resource settings. Then AHA-ACC has released a scientific statement in 2021, which offered a new guidance for management of stage 1 hypertension among patients with low atherosclerotic cardiovascular disease risk. So among low risk, that is no ASA CVD or 10-year cardiovascular risk is less than 10% with stage 1 hypertension, that is blood pressure ranging from 130 to 139 systolic and diastolic ranging from 80 to 89 millimeters of mercury. The management starts with non-pharmacological therapy. However, if the blood pressure remains uncontrolled at 3 to 6 months, then we have to start with the pharmacological therapy. This is according to Jones et al. Hypertension 2021. Then there is another fatal condition that involved lung damage. There's a potentially fatal lung damage that occurred in patients who are suffering from severe COVID-19. A recent study which appears in the Journal of American College of Cardiology reports that metoprolol can reduce lung inflammation and improve respiratory function in people with COVID-19 induced ARDS. So it has been proved that metoprolol is a very useful drug in COVID-19 patients, not only to reduce hypertension, but also to reduce the lung inflammation and also to improve respiratory function. Then another update regarding the hypertension management is lowering of systolic blood pressure targets down to 110 to less than 130. So it is between 110 to 130 millimeters of mercury. It substantially reduced cardiovascular adverse events in the step trial that confirms the sprint findings in an older individuals as far as Chinese population is concerned. So in which sprint trial, they involved 8,500 patients aged between 60 to 80 years of age, wherein which they clearly mentioned that the intensive target trimmed 26% of the composite CV risk, and findings from now second major trial supporting a lower target could unite the guidelines, which even among US professional societies ranging from thresholds of 130 to 150 millimeters of mercury. However, there has been various controversies whether to reduce the blood pressure beyond 110, especially beyond 110, definitely it is not advisable, especially in geriatric patients, because it may aggravate cerebrovascular disease and also to aggravate the stroke if you reduce the blood pressure too much below 110. So the optimal will be to maintain the blood pressure around 110 to 130 millimeters of mercury, which is confirmed by step trial and sprint findings. Then another thing I want to mention regarding the prognostic value of ambulatory blood pressure monitoring and nighttime nocturnal elevation in blood pressure monitoring. And this is clearly mentioned about the prognosis of the variation or fluctuations in the blood pressure value and also nocturnal elevation in the blood pressure value. It clearly signifies the importance of masked hypertension, wherein which the 2018 European guidelines it stresses the need for ambulatory BP monitoring and also nocturnal BP elevation to check if there is any. It recommends that the diagnosis of hypertension should not only be dependent on office readings, but also on out of office or out of clinic measurements, and in which the 24-hour BP monitoring and nighttime BP measurements are clearly associated with the greater risk of mortality and a composite of CV outcomes. Thus, they may be considered as the most relevant measurements for estimating CV risk. For every 20 by 10 millimeters of mercury increment in BP elevation, that is especially measured in the night, the risk of mortality it is increased by 23%, and the risk of cardiovascular events is increased by 36%. And another important thing regarding the 2018 European guidelines is that most patients with hypertension require lifelong medical therapy to achieve optimal control. They recommend 5 major classes of antihypertensive drugs. So considering high non-adherence treatment, the importance of combination therapy is particularly highlighted to improve adherence to therapy and BP control. Therefore, the 2018 European guidelines recommend, especially in the context of lower BP digits, to start antihypertensive therapy initially with a dual fixed dose of AC inhibitor or ARB plus calcium channel blocker or diuretic. This is according to 2018 European guidelines. Since early July 2018, products containing valsartan have been recalled worldwide. Do you know why? The reason is being the detection of a carcinogen, namely N-nitroso-dimethylamine, which can be found even in candesartan, irbesartan, losartan, olmesartan, and also valsartan. So the presence of these particular carcinogen in these drugs could lead to 8 additional cancer cases in 1 lakh patients if they had taken the highest daily doses over a period of 4 years. So the valsartan recall accompanied by a significant increase in the rate of emergency department visits of roughly around 6%. Then lastly, there is one particular study called as HYGEA study, which represents the largest study
that tested nighttime antihypertensive therapy. This is following the European 2018 guidelines. What does it say? In this trial, the chronotherapy was associated with significant reduction in endpoints, including the Hygia chronotherapy trial tested whether nighttime therapy in comparison to usual upon awakening hypertension therapy exerts a favorable cardiovascular risk reduction. It is one of the largest trial which involved roughly around 19,000 patients and the average follow-up of 6.5 years, and 1,752 patients experienced the primary CV outcome. An ambulatory BP measurement was performed for 48 hours to collect data on how BP differed during sleep. And the risk rate reduction for CV events was also significantly improved for nighttime therapy when compared to awakening treatment. So these are the various updates I have just now highlighted. Hope it will be useful for you. Thanks for the excellent opportunity given to me. Thank you.